Peripheral arterial triplex ultrasound, arterial steal phenomena, vascular steal syndrome, course when there is extensive anastomosis between two vascular beats. Arterial supply to one of these vascular beats stenosed or occluded, resulting in diversion of blood to the other vascular bead. Arterial supply to one vascular bead stenosed or occluded result in steal of blood from other arterial supply to the other vascular bead. Reduced resistance of a vascular bead result in sufficient pressure drop to attract flow from vessel or part of vessel which do not normally supply the arterial bed. Examples: in dialysis fistula, when radial artery stenosed, result in steal of blood from ulnar artery to the area hypoperfused by stenosed radial, or to the fistulous area which hypoperfused by stenosed radial artery as a result of low resistance of vascular bead supplied by stenosed artery with sufficient drop in pressure so attract or steal blood from another arterial bead, not supply this area originally. So, arterial steal phenomena occurs between two vascular beads connected by each other through collateral or anastomosis as in dialysis fistula. Presence of stenotic lesion in multiple arteries can lead to a condition called vascular steal. This occurs when dilatation of one vascular network during exercise or vasodilator therapy so steals blood from another regions within the organ that's already maximally dilated because of the presence of proximal lesion. Example: vertebral artery Doppler with subclavian carotid steal syndrome. If vertebral artery, innominate or subclavian artery occlusion proximal to origin of the vertebral artery led to upper extremity receives blood from contralateral common carotid via circle of wheels. Why? Because innominate or subclavian artery occlusion leads to decreased blood supply to the contralateral upper limb. To compensate this loss, there is blood stealing from contralateral common carotid via circle of wheels. Result retrograde flow through contralateral vertebral artery. Because blood going in reverse direction from contralateral common carotid vertebral steal to the another upper limb. Partial subclavian steal causes reversed flow only during systole, bidirectional from severe stenosis. This is examples of progression of subclavian disease result in increased peak systolic velocity inversion until peak reverse below baseline. This is vertebral artery waveform. It changes with advancing steal. In subclavian or innominate occlusion, there is steal of blood from contralateral common carotid and vertebral artery. Vertebral artery showing waveform change Firstly, in the presence of early steel, peak of vertebral artery begins to invert during systole. Progression of subclavian disease stenosis result in increased peak systolic inversion until peak reverse below baseline in vertebral artery to and fro better are seen when systolic peaks falls below baseline while diastolic continue to flow forward above baseline. More progression in final stage of the steel vertebral artery show entire waveform below baseline, continuous flow reversal. Transient sharp decline in velocity at mid-systole, producing notch and Doppler trace. This vertebral arterial Doppler waveform change indicating subclavian steel syndrome. We found in systole transient sharp decline in velocity at mid-systole, producing notch and Doppler trace. We found notch creates between two systolic peaks. First rises to acute angle. Second has a rounded contour. We have two systolic peaks. First have acute angle. Another has rounded contour velocity and notch present between two systolic peaks. We found this notch greater than any diastolic velocity. And we found also diastolic notch present early diastole. This type 1 waveform exchange with asymptomatic carotid bruit in vertebral artery. This waveform should integrate flow throughout cardiac cycle above baseline. Type 2 waveform, vertebral arterial Doppler waveform change indicating subclavian steel. In this drawing, we seen waveform change cardiac cycle. This is resembles outline profile of rabbit, sometimes referred as bunny waveform. In this waveform, more pronounced deeper cleft evident between two systolic peaks. This one systolic peaks and another notch which present in type 1, in type 2 more deep, and this is cleft velocity reached at or below that of end diastole. Velocity of the notch reached at or below that of end diastole. We found in this waveform more pronounced deeper cleft evident between two systolic peaks. Neither of this cleft reached velocity at or below that of end diastole. Second systolic peak tended to be smaller, broader than corresponding type peak 1, type 1 waveform. Type 2 waveform, left vertebral artery, typical type 2 waveform. We found notch deep between two systolic peaks and integrate flow through cardiac cycle above baseline. This is notch between two systolic peaks. Velocity may reach at or similar to or below that of end diastole. This is vertebral artery Doppler waveform change indicating subclavian stele. Type 3 waveform in vertebral artery Doppler waveform, we found drawing mid-systolic cleft, mid-systolic notch at or below baseline, but rapid recovery of forward flow before diastole shown. So all flow above baseline except mid-systolic cleft. Mid-systolic cleft at or below baseline reversed, but rapid recovery of forward flow before baseline shown. Type 3 waveform, vertebral artery. Type 4 waveform in vertebral artery Doppler changes indicating subclavian stele. Neither of mid-systolic cleft falls below baseline, signifying greater reversal of flow during systole. Mid-systolic cleft falls below baseline, signifying greater reversal of flow during systole, and forward flow restored in diastole. Type 4 waveform in vertebral artery indicating subclavian stele. Type 4 waveform transient flow reversal in mid-systole. This vertebral artery waveform indicating subclavian stele. Transient flow reversal type 4 waveform of vertebral artery in subclavian stele. Lastly, finally, retrograde flow all through cardiac cycle indicates full subclavian stele syndrome. Retrograde flow in vertebral artery all through cardiac cycle indicates full subclavian stele syndrome. Early subclavian stele waveform with continuous forward flow systolic peak inversion. This is type 1 early A. We found reversed systolic peak but flow still above baseline. Vertebral waveform is subclavian stele to and through vertebral artery waveform and waveform with continuous flow reversal finally. Stele phenomena, radiocephalic dialysis, fistula to the radial artery. We talk about there is problems in radial artery not sufficient to supply fistula, radiocephalic fistula in dialysis, so blood steal from ulnar artery via palmar arch to the fistula speed to compensate decreased amount of blood from radial artery. Radial artery steal with precious semi-fistulas. Blood flow from ulnar artery continue to fistula via palmar arch and the reversal of the distal radial artery as fistula steals blood from distal circulation. Reversal of flow in the radial artery. Radial artery proximal to radiocephalic anastomosis show normal antegrade low resistance flow. Flow in radial artery distal to anastomosis show retrograde flow toward fistula away from hand as indicated by waveform below baseline. Flow in the ipsilateral ulnar artery monophasic low resistance indicating that ulnar artery contributes to the fistula via palmar arch in the hand and the retrograde flow in the distal radial artery. Typical radial artery steal secondary to seminofistula in asymptomatic patient. Radial artery steal secondary to straight forearm synthetic graft. Flow in distal radial artery to be in same direction as flow in the graft, indicating arterial steal. Dialysis axis associated Steele syndrome, radial artery distal to radiocephalic fistula show minimal antegrade flow during systole and retrograde flow at diastole. Most of flow retrograde. Dynamic evaluation of image during graded manual compression of fistula show restoration of radial artery antegrade flow with gradual increase in peak systolic and diastolic velocities. Steele effect caused by dialysis fistula. Color flow image of dialysis graft on a native artery demonstrates Steele effect with flow reversal of distal native artery. Coronary Steele phenomena, another type of arterial Steele syndrome. Small coronary vessel dilatation lead to increase in flow to an area already well perfused myocardium. Two arteries connected by collateral vessels enter coronary Steele, leading from subendocardium, so Steele occurring through two mechanisms, either through two arteries connected to bicollateral vessels intercoronary Steele, or from subendocardium to subpericardium distal to coronary stenosis transmural Steele, leading both steels leading to decrease in flow to another area of myocardium with borderline perfusion and limited coronary reserve. This also can be seen in drugs like dipyridamole, hydralazine, isoflurane, coronary Steele phenomena as a result of affected of one small coronary vessel. Collateral Steele, coronary flow reserve at rest or under hyperemia, demonstrating mechanism of coronary Steele syndrome. Steele syndrome seen also in congenital EV malformation, Steele phenomena. Congenital EV malformation, such as in association with cerebral EVM, vein of Galen aneurysm, reduce tissue perfusion surrounding brain parenchyma, leading to brain ischemia, leading to stealing of the blood by the EVM surrounding artery. Small Steele effect caused by EVM in the frontal vital brain. EVM showing high vascularity, very low resistance of the feeding vessel, forward diastolic flow, abnormal elevated resistance surrounding artery due to Steele effects.